All right. Now we're recording. Diabetic emergencies. With diabetic emergencies, there's a problem with sugar. And we'll talk about low blood sugar. And really, what is it that they need? Sugar. And so you give them sugar, they're feeling better. So really, why do they need to go to the hospital? They don't, right? And so the easiest thing to really do is just say, okay, you don't want to go. All right, just make sure you eat. I've heard of companies that will take the patient out to the ambulance. So it's harder for the patient to say, no, I don't want to go. They'll start the IV, they'll give them the D50, and they wake up. Well, it's too late now to do anything. They're already on the way to the hospital. I don't subscribe to that, because all they're going to do at the hospital is they'll check their sugar, give them something to eat, keep an eye on them for a couple hours to make sure that they don't need anything else, that their sugar doesn't drop, and then discharge them. And now in this day and age, you really want to be sending them to a hospital where they might get exposed to COVID? Because they say like about half of all patients in hospitals now are COVID patients. I just feel it's unnecessary. So we know that sugar creates energy, right?
Yes.
And the body is going to, I'm trying to remember what I'm trying to do here. The body's trying to utilize as much sugar as possible. And it really wants to get that sugar into the to the brain, to the cells, so it could produce energy, so it functions. And so first off, because the sugar is so important, the brain doesn't need insulin to get that sugar across. The cells do, because you remember the cells have a wall that keeps a lot of stuff out. And so sugar is one of those. As much as it needs it, it still keeps it out. And so what it does, that's even worse. Yeah. Is that without that insulin, it's going to keep it out. The brain, though, says, no, it's all about me. Just like some men. It's all about me, right? So the brain doesn't require any insulin to allow that glucose to go through to feed the brain. Now, the other thing about sugar, though, about glucose, is that it also attracts water. And that's going to come into play in a little bit. Or in a little while, really. It's going to attract water. Any extra sugar that's in the body, when it gets to the kidneys, it gets filtered out. And then it gets peed out. For diabetics that have high blood sugar, when they pee it out, you could actually smell it. It smells like sugar smack 'em, that Kellogg's Honey Sugar Smacks, the frog, those corn puffs, the golden puffs. That's what they smell like. Better yet, you really want to get grossed out before dinner? Back in the old days, 1800s, 1700s, you know how they diagnosed diabetes? You're on the right path there, Miss Hannah. Yes. I can't see whose hands up.
They would taste it.
They would drink it. But yeah. In order to determine whether the patient was diabetic, they would actually drink the urine. If it was sweet, guess what? Can you imagine if that was still done nowadays? I'd be like, I'd definitely be pulling rank. It's like, yeah, this is an EMT skill. Go for it. Taste it. Let me know what you think.
Like the patient's piece?
Yeah.
Oh, hell no.
That's what they did. That's what they did. Okay. So there's an organ in the abdomen that creates a hormone that helps us regulate sugar in the body. First off, what's that organ?
Pancreas?
The pancreas. Good. And what hormone is it?
Insulin.
Insulin.
It's insulin. Now, bonus points. Where in the pancreas is the insulin produced? And in what cells in the part of the pancreas are they produced? I'm just seeing if anybody knows. I doubt it's in your book.
No, sir. I don't know.
I'm waiting for Steve to say something. Did I finally stump you, Steve?
Yeah, I don't know that one.
The beta cells in the islets of Langerhans. There's little islands within the pancreas, and they're created by beta cells, and those create insulin. So the insulin, the way to think about insulin is it's a key. The glucose has a key, and it's able to get into the cell, so it can be broken down along with oxygen to create energy. The other thing that the insulin does is that it also helps in converting glucose into glycogen. And that glycogen is stored in the liver. So, in other words, it's creating a backup energy source. Because remember how the body needs to do what it can to take care of itself? And so, by utilizing insulin, not only is it getting that insulin or that glucose into the cell, but it's also causing glucose to be converted to glycogen so it could be stored in the liver for future use. So it's a backup power supply. Now, I'm starting to eat. Let's say I have, what's a good dessert? I got some Krispy Kreme donuts here, which I don't. I wish I did, but I don't. But I have some Krispy Kreme donuts here. Best food for a diabetic, right? So I start eating it. So what is my body recognizing?
The carbohydrates in the bread.
Okay. So I'll get to carbohydrates in a little bit. But yeah, the carbs in the bread, really carbs is what the body needs to break down to create sugar. But we're not there yet. Right now, I want to know, as I'm starting to eat these donuts, what's my body recognizing? Come on, these are Krispy Kreme donuts.
The sugar glaze
The
on
sugar?
donuts.
The sugar. What about the sugar?
It's a lot of sugar.
Okay. And?
How sweet it is?
Okay. And? Okay, we've established it's a lot of sugar.
Like
Don't
the
judge.
correct type of sugar, right? It needs to be broken down.
No, it's sugar. It's glucose. No matter what,
Okay.
it's glucose.
Okay.
So what is my body recognizing right now? It already knows it's sugar because I'm laying over here fat, dumb, and happy. Not in that order. More like happy, fat, and dumb in order.
That it needs to break it down.
No. It's going to know to do it when we solve this riddle. What is my body recognizing right now?
The increase of sugar.
There you go. My blood sugar is increasing. And so my body is sending that to the brain. The brain is like, okay, so now what is my body going to do because of that higher sugar level?
It's going to release insulin.
It's going to tell my pancreas to release insulin. And so now there's insulin circulating in my bloodstream because my pancreas is attached to the bloodstream. It's putting it into the bloodstream. So we start breaking down that sugar to glycogen, and we can start getting that sugar, that glucose, into the cells. All right. So now the insulin has done its job. Now what?
So now the insulin will enter into the cells and attach to the receptors.
No, we've already talked about the insulin's already done its job. We
Okay.
already got the sugar into the cells. We already broke down other sugar into glycogen. So the job is done. Now what? Let's see. I've gone to work. I did my 8 hours. And now what? Anybody in here work?
Yes. You go
You
home.
live at work?
You go home.
There you go. You go home. The job's done. So what do you think happens to the insulin production?
Stops.
Stops.
Or I shouldn't say insulin production, the insulin release.
It
Yeah, it
stops.
stops. Because if you keep releasing insulin, guess what? Your sugar is going to drop too low. So once the sugar level is controlled, then the insulin release is stopped. Doesn't need it anymore until you start eating again. And then what happens to that sugar level again? Goes up, and we start all over. Okay, so that's the process. Now, another hormone, and this is not common knowledge, but another hormone that's produced by the pancreas is called glucagon. And additional knowledge by alpha cells in the pancreas. Now, have you ever been working hard and you're spent, but all of a sudden you get that second wind and you're full of energy again? How did that happen?
Glucagon.
Okay, and?
And it was the hormone that lets your body know to release the stored sugar in your body.
All right. So glucagon's also a hormone. So when your sugar drops, all right. So when the blood sugar drops, glucagon goes to the liver and it releases the stored glycogen. And so now that glycogen is going to get converted into glucose. So that's why insulin creates glycogen to store it away for whenever it's needed. All right. So glucagon releases that glycogen, which gets converted to glucose to create energy. Now, just so you know, too, an adrenaline rush will also help release energy. So if you need that rush, it's going to stop the release of insulin. It will cause sugar to come out and to be used. Okay. Now, one of the tests that we can do as EMTs, and I'm so happy we're able to do it without any problems. And I don't talk about California as much as I used to because they're just so backwards. Do you know that in California, getting a BGL is not part of an EMT scope? And the reason being is that hole you're putting into the finger is considered an invasive procedure because you're cutting into the body. A BGL is only a paramedic skill. Now, they are moving forward, but California is very slow in a lot of respects in that they're starting to let EMTs do it, but you have to have training and it's expanded scope. So you need additional training and certification to be able to do a BGL, which just blows my mind. Anyway, so a BGL is something that we could do as EMTs. Did you guys get to practice BGLs? Blood glucose levels? Did you guys even get to practice vital signs? No. Okay. I want to see this case stay under 1,000. We did good for 2 days, and then what was it, day before like 1,300, and yesterday was 1,500. So even though the judge's order has been ruled not valid, I'm still reluctant to really get big groups out to the school. But anyway, all right. Have you guys seen videos on how to do BGLs?
Yes,
No?
sir.
You guys, some of you have on your own time?
Yes, sir.
Well, let me, for those that haven't, I won't forget the volume. So Paula doesn't have to yell at me.
I don't yell, that's how I talk.
Just a naturally loud voice.
Hi, my name's Simon. I'm one of the final year medical students. Can I just check your name and age, please?
Yeah, it's Andrew and I'm 25.
Nice to meet you, Andrew. So today I'd like to check a blood sugar reading, if that's okay. That'll involve me taking a small blood sample from the end of your fingertip. Does that sound all right?
Yeah, that's fine.
And could I just ask you to go and wash your hands quickly with some soap and water, please?
Okay.
Whilst you wash your hands, I'll just assemble my equipment.
It's kind of funny because it said avoid alcohol pads, but that's what we use out here. I don't know anybody that doesn't use alcohol prep pads to prep the area. All right. So real quick. So they got a strip. You notice all the little whatever on the end that goes inside the glucometer, and you'll see the small little strip right here. That's where you're. It's gonna suck up the blood that it needs to do its test. Okay.
If you could just put your hand on the table for me, I'm going to take the blood sample now. So you might feel a sharp scratch. Okay.
I need to get with Vanessa to help me do some videos to show you guys. About the only time you're sitting when you're going to do a BGL is if you're in the back of the ambulance. You should be down to the patient's level right next to them. And the better thing is have them dangle their arm down. You want gravity to help you and bring the circulation down to the fingertips. So that way you don't have to stick the patient more than once. Okay. And if you have to, also, you want to, and I know I'm doing it different. Let's just pretend that's down. So you want to milk the fingers. In other words, just bring it up, milk, push the blood to the tips to make sure you get it. All right. It's kind of cheating, but you might struggle a little bit. All depends.
Shot scratch.
Oh, 15 seconds. That's an old machine.
Pinch your finger together for me.
You wipe it off, you lazy shit. Yeah, that's brilliant.
Okay, Andrew, that completes the procedure. Thank you very much. Thank you. To complete the procedure, I'll document the patient's capacity.
You see how he looked at him, how he mad dogged them as he's doing his wiping the hands? Did you see that? That was just, man, that's like micro, what do they call them? A microaggression. It was messed up. But you get the gist of it. You prepare your equipment. Some people put a Band-Aid on their glove. So after they get the sample, and while it's counting down, you just put the Band-Aid over the finger, and you're good. Okay. Yeah, that 15 seconds. Oh man, I'm very impatient. That was driving me nuts. Most of the machines nowadays are about 5 seconds or less. Yeah, I remember when it was like 15 seconds and 30 seconds. And sometimes I call it doing a D-stick, but that's back in the day when I first started, that's what it was. If anybody's ever worked in a medical clinic and done urinalysis, where you dip the strip into the urine and then you compare it, that's what we used to do with BGLs. Did you ever do that, Steve? Not the urinalysis, but the
Glucose.
D-sticks.
Yeah, in the
Where you
hospital.
put the drop of blood on that reagent strip, then you waited a minute, and then you would compare it on the bottle, what color it was, to get more or less what the BGL was.
Yeah, we did that at the beginning.
Mm-hmm. Before technology. That was something. Anyway. So that's the procedure. It's pretty simple, pretty quick. Doesn't take very long. Now, you notice the accent, and you notice the reading, 4.5 millimoles. That's another unit of measurement. Here we use milligrams per deciliter. Now, the range, your book has one range, you ask other people, you have another range. Really, the range that we look at, I'm telling you more or less. Again, different people, different references have different values. For the most part, a normal BGL reading is 80 to 120. From 80 to 120. And again, it's milligrams per deciliter, mg/d big L. Milligrams per deciliter. So when everything's working fine, blood sugar is between 80 and 120. Now, that's not to say that your sugar can't go up a little bit after eating a meal, eating something sweet. But the thing is that it goes down accordingly. It starts getting broken down, and it normalizes within a period of time. And any of you that have kids will know that. right? That orange drink. Man, I'm getting some dirty looks. Guys, be supportive. Wait till we get to OB.
Yes, sir.
Remember, it's your fault, no matter what she says. What I refer to, in case you don't know, is that pregnant women have to do what they call a glucose tolerance test. So they drink this. It looks just like orange Fanta, but does it taste like orange Fanta?
They have different flavors now. They have like fruit punch and lime.
Does it make a difference?
No, it
Nope,
still
still
tastes like crap.
Because
It tastes gross.
Huh?
I was saying they taste gross. My wife gave me some when we went one time.
All right. What a partner. I wish it tasted like those drinks, but they don't. I don't know, but I've been told many, many times. Because I used to work in a family practice clinic, and we used to do those. Give it to them and do initial blood draw or BGL, and then give it the drink. Wait a little bit, do another blood draw, and then a little while later they come in, they get another blood draw. So we wanted to see how high it went up, and then watch it come down gradually. So. Oh, Jesse, Brendan passed his test. I had a talk with him.
Yeah, he was so excited.
Although I did have 3 failures on that final. All right. So normal range is what?
Between 80 and
80 to
120.
120.
Between 80 and 120. All right. ¿Qué pasó, Gita? Now, there is a condition, and it affects a lot of Hispanics and African Americans. So that's like most of us in this room. Diabetes mellitus, that's how it's pronounced. Diabetes mellitus, or abbreviated DM. We just shorten it up and we call it diabetes, or diabetes, like Wilfred Brimley used to say. Or if you're like down in the deep south, the sugars. I got them sugars. It's a disease that affects the pancreas. What's happening is that the pancreas is not producing insulin correctly. And there's really 2 types. There's what we call type 1 diabetes. Type 1 diabetics have the problem of their pancreas not producing any insulin. Now, the unfortunate thing about that is that it's juvenile onset. So type 1 diabetes is associated with kids getting diabetes. So if you have a minor patient, they're type 1 diabetics. They're not going to be type 2. A type 2 diabetic does produce insulin, just not enough. and that's adult onset diabetes. Now, the bad thing about juvenile onset or type 1 diabetes, although I need us to say this first, it has gotten better. Back in the 80s and 90s, if someone was diagnosed with type 1 diabetes, actually even before then, up until about the 90s, it started changing. Before then, if somebody was diagnosed as a type 1 diabetic or they got diabetes when they were little, they usually lived to about their 30s. They didn't live to their 40s. However, now they're living a lot longer. One of my students, she's 47, and she's been a type 1 diabetic since she was 6. So she has gone a long time, a lot longer than she would have back in the day. So that is a benefit. That's a good thing about modern medical science. So the pancreas stops working, stops producing adequate amounts of insulin. And so without the insulin, what happens to that sugar level?
It increases.
It goes up. And as a result, the person, when they first get diagnosed with diabetes, they go through several things. There's 3 signs and symptoms that you typically will see. What are those 3 things besides the high blood sugar?
The 3 Ps, polyuria, I forget the other ones.
Like
They're on the tip of my tongue.
So somebody's trying to say them.
like polydipsia.
Okay, and
It's hunger.
polyphagia. Remember in the stroke we talked about dysphagia with a G, thinking about gastric. So here polyphagia is you're eating a lot, freaking hunger. So yeah, we call it the 3 Ps. What's polyuria?
Excessive urination.
urination.
Yeah, excessive urination. No, wait. Oh, wait, I did say polyuria, right? Yeah. Frequent
Yeah.
urination. And why is that? Ramon, who'd you piss off?
No, why? All the yelling?
Yeah,
I didn't know you could hear it. Sorry.
it's all right. Remember we talked about how water follows that glucose molecule? So if there's a lot of glucose in the blood, what's happening to water in the tissues? It's getting taken out. And all that water is ending up where? What filters out your blood?
Kidneys?
The kidneys. And so now where's that water going after it goes through the kidneys?
To the toilet.
Well, eventually, yeah. Down
To
to
your
your
bladder.
bladder first and then to the toilet. So you're peeing a lot. All right, the other one, polydipsia, which was,
Excessive thirst.
okay, why are you thirsty?
Because water is leaving your body excessively. So you need to compensate for it.
There you
Or
go.
drink.
Aren't you losing water?
Yes, sir.
And don't we get thirsty when we lose water?
Yes, sir.
So we keep drinking it. The day I went to get diagnosed for diabetes, I didn't know what was wrong with me. I just knew I was having some issues. I get to work and I drink a water bottle and I drank another one and another one. I had 7 in the span of like 30 minutes. And a friend of mine that I worked there with, she's like, you need to go get checked out. That's not normal. I'm like, okay, yeah, there's some things going on. So I did, and I told them, they're like, all right, we're going to do a BGL. It was $4.99 when I got diagnosed. And that's not the highest I've had it. I've had it at 600 at one time. And yeah, I'm proud of it. Breaking records. That's me.
I had a quick question about that, Lucas. When I got diagnosed, I never had any symptoms. You know what I mean?
How did they test you for it?
I started. I was walking, at Walmart or whatever, and all of a sudden I couldn't see any more than 4 or 5 feet ahead of me. I couldn't read any of the signs and stuff like that. So I just asked my brother to drive me to one of the emergency clinics. And even then, I went to one of them. I went to Del Sol and to Providence East, and because my mom right away, she was like, "Oh, I think your sugar is high." So we tested it with my mom's monitor, and it came out to 423. So then I was like, "Oh shit," So that's when we went to the clinics, and all they really told me was, "Well, why are you testing it if you're not diabetic?" And I'm like, "Well, because I'm experiencing all this." And so finally at Providence East, that's when they were like, oh, okay, they ran a A1C and all that, and that's when they told me that, oh yeah, you're pre-diabetic.
Well, unfortunately, I don't like that term pre-diabetic because
Yeah,
it
because
freaks
I mean,
people
you
out.
already are, right?
Huh?
Because I
Well,
mean, it's already
at 423, I mean, that's pretty high.
yeah.
You know, you're diabetic, period. It's a way to scare people and say, you need to change your diet.
Mm-hmm.
It's like, shut up. Leave me alone. That's the one thing that's the one fight I have with medicine is people telling other people how to live. We have free will. We should be able to do what we want. If we want to wreck our bodies, then we'll wreck our bodies. If we want to take care of them and, be like Mr. Olympias, then we'll freaking do that. But I think everybody should lead their lives the way they want to, happy, however they want to do it. But that's just me. I don't like to be told what to do. Can you tell? I'm a rebel.
Yes, sir.
I didn't get in trouble at the college, but they're like, Lou, our contract says we don't take more than the class max, so quit it. I'm like, fine, be that way. No, is there a history of diabetes in your family? Well, you said your mom.
Yeah, well, yes, sir. I mean, on both sides, my mom's and dad's, all my tias and tios, and.
Yeah. See, and that's the other thing too. People are like try to do whatever they can, but genes plays a big role in your health also. You could be a very healthy person. You jog, you work out, and you can still have a heart attack because it's in your genes. If there's a history of heart disease in your family, you're more prone. No matter whether you eat skinless chicken, or you eat fish or whatever. Yeah, you're doing some stuff, but you still have the genes in there that can still cause medical issues. Same thing with diabetes. My siblings have been fine, although my brother gained a lot of weight from his Marine Corps days. But in my family, on my dad's side of the family, it's like all his siblings are diabetics. His parents were diabetics. So it was kind of like, okay, I'm going to be a diabetic. My mom's side of the family, we have hypertension. So it's like, all right, pick your poison. But luckily, I don't have hypertension. Although people think I do, but I don't. I got to yell at them. Fudge. But I have the aches and pains, muscular aches and pains that my grandpa did. So I was telling my mom the other night, yeah, I really am his grandson. I got those pains now. But Apparently I have an impingement in my shoulder. That's what's causing me a lot of problems. So I'm hoping I don't need surgery. I got to go get it checked out. But anyway, so as I was mentioning, with that, it's because it runs in the family, and the vision problem is also one of those. Because of the sugar, it actually affects your eyesight, and that's another issue that I had when I was diagnosed. That your vision changes. You might, if you wear glasses, you might not need glasses because of the vision changes. Have you noticed that? Or do you wear glasses, Ramon?
No, I don't. That's actually what I was gonna tell you because I just I went and added the motorcycle. Well, I got a physical done for my CDL, and I actually have 2010 vision. You know, so that's one of the other things that I'm like, you know.
Well, just so you guys know, 20/20 vision on a normal eye chart, the letters are DEFPOTEC, DEFPOTEC. I memorized that a long time ago. I was bored. Don't ask me the other ones. All I care about is 20/20. All right, so frequent thirst because you are dehydrated. And the last one, polyphagia, you're eating a lot because isn't your body needing sugar? So you're going to eat a lot more, try to replenish that sugar. All right. Now, I want you guys to remember type 1, they don't produce insulin, whereas type 2, they do produce insulin. Okay? All right. So, the way I'm going to explain the emergencies is a little bit different. Since I don't dare attack the women, I'm going to attack the guys. And Gabe's very quiet. I know he's around somewhere. He just doesn't want me to pick on him anymore because he doesn't pop up. So I'm going to pick on Ricardo. Hi, Ricardo. So, Ricardo, you know, we're in November, so obviously it's the turkey and tamales and buñuelos season. Uh-huh. I hate this app sometimes. So anyway, but right after, he's trying to get ready for the beach. And the quickest way he knows is, are you guys familiar with the Atkins diet? No, that's so
Yes,
like
sir.
last decade.
Yeah, it's all
Some of
protein.
you are, okay. Well, the newest fad diet is the keto diet. But I like Atkins better because you could eat all the hamburgers you wanted and all the steak you wanted. I don't know about keto. I see a lot of roughage. I don't like roughage.
It's supposed to be no carbs, no grains, pastas, stuff like that.
Yeah.
It still sounds healthy. I don't do healthy. I've worked very hard for this body, damn it. All right. So I'll just interpose both of them. So somebody said no carbs. We already talked about what happens with carbs. right? Which is what's the body do with carbs?
Produces energy.
Huh?
Produce energy.
There
so that
you
to
go.
make ATP.
The body breaks down the carbs to create sugars, to create energy, glucose. All right, we need carbs in our diet. However, both of those diets eliminate carbs. And the theory is by eliminating carbs, you lose weight. How does that work? How are you losing weight by eliminating carbs? That is a $64,000 question, isn't it?
So you have to find a new fuel source. So instead of breaking down carbs, you start to break down other things like fat, protein, and that's your main source instead of the carbohydrates.
Well, protein is kind of a last resort, but yes, and you touched on both of the things I'm going to talk about. The body needs to find another source because it's not getting that glucose from the carbs anymore. So it has to go somewhere else. And so the biggest source, no pun intended, is fat. Some of us have a little extra, right? Or wait, let me rephrase that. Sorry, everybody. I have a lot of extra of that. I don't want anybody to get offended. Steve.
No offense taken.
All right. It means it's good home cooking, right?
Right.
That's my excuse. Oh, you should have seen my lunch my mom made me today. I'm a cheaply. I'm a mama's boy. I admit it. So it goes to the fat and it breaks it down. So cool. There's extra fat. Somebody that's on a diet obviously has a little extra fat. Now, here's the problem. When we break down fats, we create something else. What do we create? Here's where the problem develops. And then the rest of it is going to sound familiar. What do we create?
Ketones.
Ketones. Exactly. Good job, Candace. By the way, you're not the first person I changed their name to. I've had a student in both my EMT class and advanced class. His name's Arturo, but I always call him Brian. And I don't know where I got Brian from Arturo. So you're in good company. So Candace, good. When we break down fats, we create ketones. Well, are ketones good for the body?
Nope.
Nope. Body don't like that. And when the body don't like it, what does it do? It converts it to something it does. Well, here's what ketones produce in the body. Acids. Is that starting to sound a little familiar? Yep.
Yes.
How so? Or let me rephrase that.
It sounds like anaerobic.
Okay, keep going. So what's the process? We create breaking down fat will create ketones, and then the body releases bicarbonate, which breaks it down into carbonic acid. And when the body further breaks it down into sugar and carbon dioxide. Well, what does the body, no, not sugar, water and carbon dioxide. What does the body do with the water?
You expel
Reabsorbs
it.
it. Huh?
I thought you expelled it.
No, it reabsorbs it back into the body because doesn't it need water? Yep. And so what does it do with the carbon dioxide? Well, we're not in dehydration yet. But high levels of glucose will lead to dehydration, and we already talked about why. This part should sound familiar. If we've broken it down also into carbon dioxide, what's the body doing with that carbon dioxide?
Once it expels it to exhalation.
Yep. And from yesterday, remember we talked about that yesterday? What happens to the respiratory rate?
Increases.
This.
It goes up. Because isn't there more carbon dioxide than there was before?
Yes, sir.
Yeah. Now, women and some guys, let's be fair, and some guys will use a form of ketone for beauty needs. Where? Have you taken off nail polish recently? What did you use to take off that nail polish?
Acetone.
Acetone. Acetone's or ketone's a type of acetone. So when that person is exhaling, might you smell something?
That could smell like acetone.
Okay. A sweet, fruity odor to the breath?
Yes, sir.
Yeah. That's because of the increased carbon dioxide. And because it has ketones in it. And the way they're breathing, though, is unlike normal elevated carbon dioxide levels. In this case, it's pursed lip breathing, and it's fast. And we call that, what do we call that type of breathing? Kuzma respirations. Because of that excess carbon dioxide. Just trying to blow it off. But because of the ketone, it's also going to smell fruity. Tell your sister I just saw her armpits.
I'm gonna tell her so she doesn't come steal my fries.
There you go. But they do say that other people's fries taste better.
It is true. It
I
is
know it
true.
is.
I used to work at McDonald's and they didn't taste the same.
Exactly. Yeah, I do believe in that theory. I've proven it too. Yeah, so Kuzma respirations as a result of that, of the ketones within the breath, within the carbon dioxide. Okay. All right. Now, so the other signs, and to kind of go what somebody else had said, so because there's all this sugar, right? Well, first off, so going back to the diet and with this type of emergency, which I haven't told you what it is yet, but because of the high sugar level, the body's not able, or the body cells are not getting that sugar, right? And so it's getting tired of waiting. So I was going to compare it to a guy going somewhere else to look for what it needs, but I won't. But it does. These cells go and say, come here, you. It breaks down fat. And so going back to the diet, that's why they lose weight, because the body is breaking down that fat to create the energy. You see? It needs that sugar and it can't find it, so it'll create that sugar by breaking down fat. Thus, the person loses weight. So one reason why diabetic, well, first off in the diet, that's why they lose weight, because they're losing body fat. But two, that's why diabetics will lose weight, because their body is breaking down fat to create energy. Because without that insulin, they're not getting that glucose. It's there, but it's not going to the cell because there's no insulin to get that sugar into the cell. Or there's not enough insulin too. Okay. And so the other thing that we will see is, we saw the 3 Ps. And so excessive thirst, excessive urination, and frequent or excessive hunger. We haven't talked about environmental emergencies yet. However, in environmental, what is your body like when it's dehydrated? You've basically lost a lot of volume, have you not? From excessive sweating, excessive peeing. So are you thirsty? Yeah. And then what are your skin signs like? What are your skin signs like when you're dehydrated?
How does some dry, Nolu?
Dry, maybe a little flushed. Okay. Well, with hyperglycemia, aren't you dehydrated? Yeah. So a way to think about hyperglycemia, too much blood sugar, is like dehydration. So what we've been talking about deals with hyperglycemia, high blood sugar. They will have some of the same signs and symptoms as dehydration. Their heart rate's going to be elevated, although it'll be with both. Their skins are going to be warm and dry and flushed. Now, the condition we've talked about with the Kuzma respirations, with fruity odor to the breath, with frequent urination, all that stuff. It's what we call diabetic ketoacidosis, or DKA. But here's the big thing you have to remember. Here's what you have to remember. Only type 1 diabetics can suffer from DKA. So if they have Kuzma respirations, you have a fruity odor to the breath, those are the big ones. Only type 1 diabetics will have that, or will get that. Type 2 diabetics, we're special. Hi, Ramon.
Yes, sir, of course. Ya se la sabe.
Exactly. We don't go into DKA. And I forget what your book calls it. Hyperosmolar, hyper something, ketoacidotic, blah, 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 blah. I know it as HHNK. Hyperosmotic, hyper keto something, or non-ketotic something. Not DKA, basically. Not the Kuzma respirations, not the fruity odor. But it is breaking down fat to create energy, so we have buildup of ketones. So that's the difference between the two. If they're in DKA, the fruity odor, the Kuzma respirations, that's DKA, and that's type 1 diabetic. Now, the other thing about DKA is a type 1 diabetic can go into DKA with a low blood sugar. In other words, about 200, they can go in DKA. If they go a lot higher than that, like if they were to reach Ramon's 420 or my 499 or even my 600, that they're pretty much almost dead. They don't do very well with it. So their sugar doesn't have to be that high for them to go into DKA. Whereas a type 2 diabetic and HHNK, like I said, 600, 500, 400, 300 without batting a lash. Now, so let's back up a little bit. Hyperglycemia is elevated blood sugar. So we're not at DKA, we're not at HHNK. Just it's above 120. The person might not be feeling very well. They might be tired. Yeah, they could be thirsty. They could be hungry. They could be peeing a lot. Now, the big thing to remember, and this is one of two things that will help you determine whether the patient has high blood sugar or low blood sugar. The onset of symptoms. With hyperglycemia or high blood sugar, we're talking about a gradual onset. It occurs over several days. The second clue is the skin signs. Second clue is the skin signs. So what do you think causes of high blood sugar are?
Diet.
Okay, diet or lack thereof. So enjoying too many Krispy Kreme donuts, too many Well, we just had Halloween, so eating all the kids' candies. Yeah, 3 bags, and of course Halloween was canceled. So guess what? You can't let those 3 bags go to waste, right? You like my logic? I like it too. My blood sugar yesterday morning was like 91, so it's like, leave me alone. My sugar's good. What was your last A1C, Ramon?
Wasn't too bad. It was, I guess, kind of high, 7.4.
Okay. Well, they want it under 7.
Yes, sir.
Mine was 6.2. Woohoo!
Nice. Are you, if you don't mind me asking, are you on insulin or just pills?
No, I'm on insulin. And I've been able to stop one of my pills, so, and it's still staying pretty good. So, you know, knock on wood, God willing, it'll keep staying good.
Oh, nice. Now I'm just on pills, but I'm trying to work it to where, bring it down without having to take many pills.
The A1C is basically an average of your sugars for the last 3 months, because it takes about 3 months for your blood cells to recycle. Even though they only last about a month, it still takes about 3 months to recycle all of it. And so for diabetics, they really want it under 7. For non-diabetics, they want it under 6. Or actually, I think under 5. So that's a question you could ask them. And you noticed he asked me about insulin. So that's a question you want to ask your patients as well. What kind of medicines are they on? I'm going to tell you right now, you better learn some meds real quick before before Wednesday, because the quiz will give you a couple medications. You got to recognize the diabetic ones. The most common one out there is metformin. Then you have the insulins, and they have new names for insulins.
So no glyburide or anything like that.
I don't remember about glyburide, but that's a diabetic one. Glipizide, I think it's the same thing. Diabeta, Bidareta. They have some of the newer ones, Tugel, Tresiba, Ozempic was once a week. Victoza is once a week. And then you have the old insulins, which are still pricey. Lantus,
Humalog, Humulin.
Humulin, yeah, Novolin.
I think Invokana is a new one too, isn't it?
Yes. Then you got things like Farxiga. You have Levemir, which I'm allergic to. Januvia. I used to take that, but pretty pricey drug. I stopped taking it. There was another one too besides Januvia. Can't think about it, or can't think of it. Anyway, so going back. So I forgot the question I had asked you guys. Oh, what else can cause high blood sugar? So diet. We've kind of been talking about it for the last 2 minutes. What's a problem that a lot of diabetics face today? Or better yet, what's a problem that a lot of people face today when it comes to medicines?
Forget to take it.
Well, that's the other one.
They can't.
Price.
Can't afford it.
Go ahead, Candace.
Oh, I just
How
said they
rude,
can't
huh?
afford
Sorry.
it.
Huh?
They can't afford it.
There you go. Here I am getting on everybody for interrupting you, and then not go in and interrupt. Jeez, bad loop. Yeah, they can't afford it. Insulin is one of those that's pretty expensive. Pretty expensive. And so some people, I remember my dad, he had to take medicine for clots that he had in his legs, and he was running out, and it was really expensive. So he started taking it every other day instead, and he ended up having a heart attack a few months later, or a month and a half later. So, yeah, it gets pretty pricey, and people on fixed incomes on Social Security, they can't afford it. So they don't take their meds because they can't afford their meds. Maybe they can afford them or whatever, they get assistance, but they still don't take them. Mexican males aren't stubborn, are they? Paula just looked up like, yeah, right. What about sickness, illness? Can that cause blood sugar levels to go up?
Infections, notice?
Yeah, infections as well. So there are certain things that will cause an increase in the blood sugar. All right. Now, on the flip side, so you already know this, but for this scenario, I'm a diabetic. And it's 7 a.m. And so I wake up, I take my insulin, intending to eat. But for whatever reason, I didn't eat. So now it's 9:30. And man, I'm not feeling very well. And I get pale, cool, and clammy. And I feel like I'm gonna pass out. What happened?
Your blood sugar decreased.
Okay. I took the insulin, but I didn't eat any food to help that sugar or to create that sugar to go into the cell. So whatever sugar I had too much insulin in my body. And now it almost wiped out all the glucose I had. So what's my sugar level like?
Hypoglycemic.
Hypoglycemia. Now, some of you might be familiar with the terms diabetic coma and insulin shock. Diabetic coma is what we now call hyperglycemic crisis or hyperglycemia emergency. Their sugar's high. Whereas the insulin shock is low blood sugar, hypoglycemia. Okay, so those terms we used to use, the diabetic coma and the insulin shock. We don't use those anymore. Okay, so get those out of your mind. Now they're hyper or hyperglycemia. Hyper or hypo. All right. So what are you going to see in a patient that is suffering from low blood sugar or hypoglycemia?
Confused.
Okay, confusion.
Yeah, like an altered mental.
Ultramental status. Although you will also see it in hyperglycemia.
Okay.
Diaphoretic.
Okay. Diaphoresis. What else?
They're pale.
Pale skin.
Don't they smell like alcohol?
No.
Or was that the other one?
The other one.
They
Remember,
get really
we gotta-
shaky.
Okay, tremors. What's the onset? I'm sorry, what was that?
Wouldn't it be also be like have nausea?
Yeah, yeah, I can. Now, what's the onset?
Quick.
It's a sudden onset. So remember, we talked about two things with hyperglycemia, the skin and the onset. Well, with hypo, it's the same thing. The skins and the onset. With hyper, what are the skin signs?
Like dehydration?
Okay, which are?
Dry skin, like flush.
Okay, dry flush skin. And what about the onset?
It's over the course of a few days.
It's gradual, yes. Whereas now with hypoglycemia, what are the skins?
Should be more like shock, right? Like cool and
Pelco and diaphoretic. And what's the onset?
Rapid.
Yep. Sudden onset. So you see the difference between the two? That's how you can tell the difference between hyperglycemia and hypoglycemia. The onset and the skins. Now, someone mentioned intoxication. A hypoglycemic patient, or even hyper, may resemble being intoxicated. But remember what we've said about assumptions. Don't ever assume anything. So just because they appear to be intoxicated doesn't mean that they are intoxicated. There might be a medical reason as to why. So rule that out first. Okay, roll that out first. All right. All right. So let's talk about treatment of high blood sugar. What can we do for treatment for high blood sugar?
could assist with insulin.
Nope.
No.
Nope. It's pretty much nothing. Take him to the hospital. Now, if you take my advanced class, you'll find out what you can do, which does not include insulin. All right. If they have low blood sugar, what can you do?
Administer glucose.
Okay. Are there any contraindications to administering that glucose?
They have to be able to swallow.
Okay, they have to be able to swallow, but they also have to be able to protect their own airway. How do we know if they can protect their airway?
They have to hold it.
Yep. So you grab a tube of glucose, that glucose gel, put it in their hand, and tell them to take it. So they have to be able to hold it in their hand. If they cannot, then they cannot protect their airway. Now, is there something that you can do if they can't protect their airway to give them sugar besides call for ALS? So I'm not letting you off the hook that easy. Didn't we talk about putting it on a tongue depressor and putting it between the cheek and the gum?
Yes.
Yes, sir.
Mm-hmm. All right, your book calls it HHS, hyperglycemic hyperosmolar syndrome. So how can you tell the difference between the two?
Skin and onset.
No, of DKA versus HHS.
Well, the type of diabetic they are.
Okay, what do you mean?
Well, only a type 1 diabetic can experience that.
Which one?
Type 1?
Okay. In the HHS?
Type 2?
Type 2. Yep. All right. All right, your book has a list of different medications that diabetics will be on. You talked about insulin, you got Actos, Diabinase, Oronase. Usually they end in A's. Macronase, you got Diabeta, Glucotrol, Humalog, Glucophage, which is also metformin, Byetta. So find out what medicines they're on. I remember there's an app did I tell you guys about Hippocrates?
Yes.
You could use that. If they're altered, ask the patient's family. Do they have any medical problems? Any heart problems, diabetes, high blood pressure? Any other questions you can think of that you would ask that patient?
What was the question again? I'm sorry.
Are there any other questions you could think of that we could ask the patient or the family members?
When was the last time they took their medication?
Yeah. Or when was the last time they ate?
Okay, good.
Unusual exercises.
Okay, any unusual activity? So yeah, if they don't normally work out, all of a sudden they're working out, okay. Because if they're used to taking so much insulin for little activity, now all of a sudden, same amount of insulin, but more activity, they're gonna have a problem. Have they been sick? Now, there's a big one that I'm thinking about that is good to know.
Their last reading, maybe?
Okay. Ow. But let's go a little bit beyond that. So I take my patient's blood sugar and it reads at 248. And they're type 2 diabetic. And the reason I'm giving you that number is because you'll have Hispanics that read that. But why is it important? Or what's important about that number?
What do they normally run?
There you go. We want to know what they're normally running at, because that 248 might be normal. But if they say, oh, I normally run at 180, around 180, okay, that 240 is higher. But they normally run at 300, guess what? Because also, if they normally run higher, and that reading is a high reading, but for them that's low, they might be feeling like they're hypoglycemic because their body is used to a higher level. So make sure you also ask, what do you normally run at? So we have something to compare it to. They shouldn't be running high, and I'm not no one to talk because I normally did run high. But the body gets used to that. Because I was running 200 to 300 or closer to 3. And so if my sugar dropped under 200, I was feeling weak. So it took a while before my body got used to the lower readings before it started getting better. And I know my body, and I know.
Yeah, I had the same thing. I started off with like 240s, and then as soon as I would get like into the 120s, I'd feel like shit.
Yep, because our body gets used to those levels. And so let's get a comparison. Let's get a comparison. All right. Now, let me ask you this. The patient, they're able to hold on to the tube, but they're feeling weak. Now, you want to give them glucose. Do you give them glucose?
Yes, but between their cheek and gum, don't let them take it themselves.
But they're able to hold it. They're talking to you, they just say they feel like crap. And you don't know, and there's no glucometer. So you still give it to him?
Yes. Because you have to play on the side of caution. I mean, to know if they're high or low, but isn't that how it works?
I don't know. I want to get some more opinions.
But then if you give them too much, that can be dangerous too,
Yeah,
no?
that can be fatal, can it?
Yeah. So I would say no on the glucose and transport them.
Anybody else?
Yeah, I agree with what Ramon said. Just to take them to hospital instead.
I say give it to him.
If their sugar's high and you give them sugar, we know the sugar is going to go higher. Okay. You're really not doing more damage. It's already high. What's a little bit higher? Although Candace has a very good point about it could be bad if they're in DKA, you put them, you give them more sugar. But yeah, at the hospital, we'll give them insulin. And if you get ALS out there, here's a treatment that ALS can do. Start an IV, start giving you fluids to dilute the blood. So it's not a lost case. Okay. Now, if their sugar's low, isn't there, they benefit from sugar? So as long as they can take the sugar, there's really, it's a win-win. Or it's not a lose-lose. So if it was low, hey, you helped them. If it was high, you didn't hurt them. But did we find out ways that we could determine whether it's high or low?
Onset and skin.
What was that?
Onset and skin.
Yeah. But just so you know, if you need to give them sugar, then go for it. Okay. All right. So what's the normal sugar range?
80 to 120.
80
80 to
and
120. Okay. We know what happens when the sugar is too high. We know what happens when it gets too low. We know about the different types of diabetes, which are
Type 1 and type 2.
type 1 and type 2 diabetes. What's another word for type 1 diabetes? Or another phrase? Juvenile onset, and they're also known as insulin dependent diabetics. What about type 2?
Adult onset.
Adult onset diabetes. And now with adult onset diabetes, you could have insulin dependent diabetics and non-insulin dependent diabetics. But type 1 are only insulin dependent. So if they take oral medications, they're type 2 diabetics. You won't find type 1 diabetics taking oral meds. And some of them might even have an insulin pump. It's another way to tell, well, Type 2 diabetics can also use insulin pumps. But what an insulin pump is just a pump that is feeding insulin into the body at a preset rate. They need the insulin. They need that insulin to regulate their sugars. So, so diabetes is a common medical emergency that we go, that we go on. It's not as bad. Hypoglycemic patients don't require a lot. If we can get their blood sugar, they don't really need to go, because let's say they're altered. What are they needing? If they're diabetic and they're altered, what are they needing?
Sugar?
Sugar, glucose. Now, the other thing is, are they able to consent? Are they legally able to consent? So yes or no? Go with your gut instinct. Are they legally able to consent if they're altered?
No.
Okay, I saw Sharon say no with her head. So no. See, you are paying attention. They can't consent. Now we give them the sugar. They wake up, they're A&O times 4. Can they now consent?
Yes.
Yes. So are we going to force them anywhere if they can consent?
No.
No.
They A&O times 4 and they say, you know what? I'm good now. I don't need to go. What are you going to do? Sorry, you have to go.
Sign my consent.
Exactly. No, refusal. Sign my refusal. So don't push it. Again, I disagree with companies that want to take the patient just to make money. I don't think that's in the patient's best interest, honestly. So, all right. So if they're altered, remember AIU tips. Start going down the line. Is it alcohol related? Is it epilepsy related? We talked about epilepsy, seizures. Usually you'll see them incontinent. They might have some oral trauma where they might have some blood coming out of their mouth because they bit their lip, their tongue. So they might have some blood coming out. Insulin. Now we could get a BGL. And remember, BGL is sugar's part of your vital signs. Now, I think, no, you guys already had that question. It should be one of the vital signs that you get, BGLs, just to rule it out. So if it comes back that the sugar is low or high, well, you got a pretty good idea. And then start looking for other things in your assessment that's going to reinforce your diagnosis. But you still have your differential diagnosis. Okay. Questions? All right. You guys want to take a break and come back, or you guys want to call it a night? It's your guys'
gone over
class.
everything?
Huh?
Have we gone over everything?
Yes, ma'am. Well, you guys tell me. You guys read the book, right?
I think it's a fairly easy subject, Luke.
Uh-huh.
I vote call it a night.
Let's call it a night.
Where's the class prez? still driving. He's like, nope,
Yeah,
take
I'm
a break.
almost home.
Huh?
Yeah, I'm almost home.
See, so you were in
But
class.
I've been listening. Yeah, I agree with Ramon.
Okay, no. Not in here. No.
I have a question.
Yes.
When will you be revising grades again to look over that?
I could do some for Wednesday, or wait till the next exam and put them out next week.
I can wait till next week.
All right then. It's 8:17. You guys have a wonderful night. Study.
To see you Wednesday.
All righty, study. Quiz on Wednesday. All right. Good night, everybody. Thank you.
Sir.
Sounds good.
Have a good
Thank
night.
you.
Bye.
I will try to get more videos put up. I promise.
English,
English what?
regular English, not British,
Huh?
not British videos.
I mean, oh, no, my videos. Not those videos. Those suck.
All right.
All right. No promises, though.
All right. Good night.
Night.
All right. Bye, everybody.